Hi, I'm Steve Selling, founder of Fit Test, and in this series of short videos on chronic heart failure and exercise for exercise professionals, the topic of this video is, first of all, what is heart failure? Secondly, to look at the effect of VO2 peak, or the power of VO2 peak in predicting mortality in people with heart failure, and I'll present a case study at the end of this short video. So what is heart failure? If we look at a healthy looking heart muscle here, it's got nice coronary arteries that are supplying lots of oxygenated blood. And then we look what happens in heart failure in cartoon form. So the heart here is struggling to get cardiac output out of the both sides of the heart. So struggling to pump blood, and that's really what you think about as heart failure. There are different forms of heart failure that I'll go through in more detail in this series of videos, but really just this cartoon, I think, expresses quite nicely the problem of heart failure for your clients. So what is heart failure in more detail, a bit more physiology here? The hallmark sign, the unifying sign, is low cardiac output at rest and during submaximal and maximal exercise. So every part of someone's life with heart failure, the unifying feature is low cardiac output. Now, just to remember or remind how cardiac output is important for the body, it's important in supplying oxygen to the body, in the sense that the FIC formula for whole body oxygen is cardiac output, which is made up of two components, heart rate and stroke volume, multiplied by the oxygen concentration difference between the arteries and the mixed venous blood. And I've covered this FIC formula in other videos in my series on YouTube. So just to come to cardiac output and its two components of heart rate and stroke volume, in the setting of this video, we're really talking about stroke volume, and heart rate is not part of it. I would say at the outset though, and this is maybe a little bit counterintuitive, is that cardiologists prescribe drugs which will lower cardiac output, and they do it for different reasons. They do it to lower the work of the heart. So even knowing that it might have a negative effect, if you like, on cardiac output, it saves lives by reducing the work of the heart. And it's separate to what I'm talking about here. So what I'm talking about in this video is predominantly around stroke volume. There's also a cardiac version of this FIC formula, and I'm not going to talk about it in this video, but I've spoken about this in numerous other videos you can find in my YouTube channel. Coronary artery blood flow times O2 arterial minus coronary artery blood flow times O2 sinus. And if we look at O2 arterial, by far the most dominant components of O2 arterial are hemoglobin concentration, in other words, treat anemias, and oxygen saturation, in other words, treat any lung problems, but also heart failure can result in low oxygen saturation in arterial blood. These are not the topics of this video though. So the hallmark symptoms, we've covered the hallmark sign, now the symptoms. The first hallmark symptom or unifying symptom is breathlessness on exertion and also breathlessness at rest. So shortness of breath on exertion and also shortness of breath just at rest. And the second one is fatigue during exercise and even at rest for people who are very sick. So they're the two hallmark symptoms. Now we come to the functional classification scheme. The most universally supported scheme is that published by the New York Heart Association, NYHA. So New York Heart Association Class 1, which are the high-level clients, the functioning clients, these clients only have symptoms at high-intensity exercise, and you can exercise them almost as if they're normal, provided they don't have other comorbidities that need to be addressed. So these are essentially normal, and you can treat them as basically healthy people, although they've got a history of heart disease. In Class 2, New York Heart Association Class 2, they have symptoms at moderate intensity exercise, and Class 3 have symptoms at low intensity exercise. Class 4 have symptoms at rest, and these are very difficult clients, or really unsuited to whole body exercise. they can do small muscle group exercise, seated or chair-based exercise is fine, but usually you need to confine the exercise to light loads, low intensity, low muscle group, small muscle group involvement, plenty of rest. Interval training is good. In fact, interval training is good for all of these heart failure clients because they get that rest interval to recover, and then they can generally operate at a higher intensity when they come back into the exercise mode. So yes, New York Heart Association, it's not contraindicated to exercise, but they're so symptomatic that usually that takes care of itself and that you can only get very light loads of exercise into them. Now, finally, before I leave this slide, there's a couple of other concepts, and that is we have two sort of major classifications of heart failure based on pathology. So the top ones, New York Heart Association, is based on functional class, or if you like, exercise ability. And these last two here, heart failure with reduced ejection fraction and heart failure with preserved ejection fraction, this relates more to pathology. And so systole is when the heart is pumping, diastole is when the heart is relaxing, and we have forms of heart failure with both of these. Now, in the case of reduced ejection fraction, that means the heart has less ability to pump blood per beat. It can't pump out as much per beat as it would like to do. So ejection fraction refers to the amount of blood pumped out in a single beat as a fraction of how much blood was in the pumping chamber, the ventricle, at the end of the relaxation phase. So after filling, the ejection fraction is how much was pumped out compared to how much the filling was just before that. And for diastolic heart failure, they have normal ejection fractions. That's not their problem. Their problem is with diastole, the ability to fill the heart. And the next slide will show this quite nicely. So here we have the next slide with heart failure with reduced ejection fraction. And the problem here, well, first of all, I'll just look at the normal heart. So in the normal heart, we've got normal muscle wall thickness, normal muscle size. Here we have decent cardiac output, normal cardiac output going out into the aorta, proper pumping function of that normal heart. Now, heart failure with reduced ejection fraction, as you can just tell, maybe there's an enlargement of the chamber size compared to this chamber size here. The chamber's larger. I've actually covered this very nicely in the Frank Starling law of the heart on my YouTube channel, which you can get a copy of that video and look at that. Talks about this a lot. So the weakened heart muscle, stretched out heart muscle, dilated, larger chamber size, but very poorly functioning when it goes to pump. So less blood pumped out during the pumping phase, and you can see that by the relative size of the arrows in the pumping out phase, or the systole. So this is systole here, this red arrow. Now this red arrow here refers to filling, or the diastole, the diastole from the coming from the blood coming back from the lungs and filling the ventricle. Now, in a heart failure with preserved ejection fraction, this heart is called diastolic heart failure, and it is reflected or shown as a stiff, thick-walled heart that can't relax properly, and so it has problems with the filling. So it's not the problem with the pumping so much, although the stiffening wall here, the stiff wall here, also isn't particularly good for contraction and injecting blood out. But that's not the primary problem. The primary problem is on the filling side. That is because the heart muscle is so thick-walled and stiff that it can't fill properly. And that's called heart failure with preserved ejection fraction, or diastolic heart failure. Now we come to VO2 peak, because we've already mentioned that in this video. And VO2 peak, this is the cumulative of the cardiac event-free survival. So the higher you stay up here over a period of 5 years, so this was 5-year follow-up, the higher you stay here, the greater the chance of survival. So the black line here is the better line, And these are people with VO2 peak on the higher side with heart failure, whereas those with heart failure with peak VO2 or VO2 peak falling below 18, which you can estimate using fit test, then these are the people who are in much worse condition in terms of survival. Now, similar, or following on a similar theme, but this one over here on the left was for a form of heart failure called dilated cardiomyopathy. And this is for a different group of patients, a different study, but the same sort of concept here. And the survival here with heart failure with a peak over 14 mils per kilogram per minute, they had 16-month survival of 91%, whereas those with a very low VO2 peak had a very low survival of less than 50% at 16 months. So the VO2 peak is a good thing to know in heart failure, and my app Fit Test will provide you with an ability to estimate that VO2 peak. Now, continuing on, this is incident hospitalisation for heart failure, and in black we have reduced ejection fraction, in red we have preserved ejection fraction, and in green we have mid-range ejection fraction in green. Now you'll see there's an inflection point where the flattish graphs here turn upwards steeply when VO2 peak goes under that magic number of 14 mil per kilogram per minute. So when it goes under 14, the incidence of hospitalisation goes up a lot, and that fits in with the mortality data. And then to continue on, and this is a complicated part of the slide, and I'm going to cover this more in another video, so I'm going to not spend a lot of time on that. But it's the same sort of concept again. This is the survival, including survival and heart transplantation and a few other things. And the four graphs are, starting from the bottom, heart failure with reduced ejection fraction, mid-range ejection fraction, preserved ejection fraction. And these ones at the top are mid-range ejection fraction who actually got a cure or somewhat of a cure and were able to return the ejection fraction back to near normal. And these had even better survival curves. But I'll have more to say about this slide in a future video. Now, coming to cardiac rehabilitation, including supervised exercise and its effect on mortality in survivors of myocardial infarction. First of all, the risk ratio is when it falls below 0, that's a good thing. It means the risk of the exercising clients has improved, or lower risk compared to those who are doing no exercise. So the lower this number, the greater the reduction in risk for those doing exercise compared to the sedentary patients. And these are survivors of myocardial infarction or heart attack. A lot of these will have heart failure. So for exercise only in a cardiac rehab program, the risk is reduced by 28%. For a general cardiac rehab program, but without exercise, the risk reduction is still decent at 13%, but not as good as when exercise is included. And believe it or not, when cardiac rehab is included with exercise, for some reason the risk ratio was 12% compared to 28% for exercise only. Now, these are different groups of patients, and I'm sure those individual differences are because of the types of patients who have been included in these cardiac rehab programs. But the general concept is cardiac rehab saves lives in people who have survived a myocardial infarction or heart attack and maybe have heart failure. So, and particularly with exercise, should be included in every cardiac rehab program where you can. Now, I come to my case study, the presentation. In 1999, the client had a myocardial infarction with a region of the heart not specified, gradual deterioration into heart failure with shortness of breath on exertion. In 2007, diagnosed with systolic heart failure with regions of akinesis, which means no movement or no contraction of that region of the heart, and dyskinesis means inappropriate or muscle contractions going in the wrong direction and really not contributing, in fact, taking away from cardiac output. And at this time, the client had been diagnosed to have deteriorated to heart failure New York Heart Association class 3B, which is just better than 4 during this period. So symptoms of mild exercise for this client. And he was only 53 years of age when I saw him. So in 2007 also, he had a 3-lead pacemaker. That's a 3-wire pacemaker with cardiac resynchronized therapy, which means 2 wires in, or 1 wire in each of the left and right ventricles. And by pacing both ventricles together, we get coordination of that's why it's called cardiac resynchronization, coordination of left and right ventricle. And this usually achieves better clinical outcomes. And he had improved shortness of breath on exertion, and he improved his New York functional class to class 2 as a result of the pacemaker being fitted. So it made quite a difference. Now, in 2013, or just before I saw him, his pacemaker unfortunately needed to be replaced due to an infection. And at that time, he also had an implantable cardio defibrillator fitted. And again, that improved his shortness of breath on exertion. So his medications, cavetilol, which is a beta receptor blocker and an alpha receptor blocker. The beta receptor blocker works mainly on the heart and to decrease the work of the heart and to decrease afterload, blood pressure, and so on. Whereas the alpha receptor blocker specifically relaxes the peripheral arteries and reduces afterload to reduce the work of the heart. And all of these concepts I've covered in other videos on my YouTube channel. Digoxin is an AB nodal blocker. That's not the purpose it was given here, because there's plenty of beta blockade going on. Digoxin for this client was given as an inotrope, in other words, as a cardiac stimulant to try to maintain stroke volume and therefore maintain cardiac output and oxygen supply to the body and the heart. Spironolactone, potassium-sparing diuretic, was given to reduce the work of the heart, the fluid load of the heart. Again, my video on Frank-Starling law of the heart goes over this concept in detail. Furosemide, a loop diuretic, same effect on the Frank-Starling law of the heart. And warfarin was given as a background anticoagulant, and that's a vitamin K antagonist. Now, coming to his exercise test, we got to 82% of his age predicted heart rate peak, but this was because his rhythm was paced. We think it was paced throughout exercise. And again, this emphasises why in fit test, we have control over these heart rate interpretations, and you're not locked into 100% of age predicted heart rate peak, which is a great strength of my app fit test and allows us to really analyse what's going on here. And VO2 peak was estimated to be 21.6 mils per kilogram per minute, obviously lowish for a 53-year-old male. Now we come to ECG. I won't dwell on this too long because most of you won't be working with ECG, but just to show you what pacemakers happening in this case, you can see the pacemaker spike here, followed by the ventricular response. There are also some P waves here, which would have been paced by the atrial pacing wire, I think. And we have a locked-in heart rate of 80 at rest. When he went to exercise, you'll notice the shape of the ventricular activation has changed noticeably here. And I think he's still being paced in here, but I'm not entirely sure about that. I'll show you a bit more in a minute. There's certainly the pacing characteristics have changed. I think he's still being paced here, but I'm not 100% sure. If I'm not, then this is a ventricular rhythm through here. He's still got visible P waves here though. And when we went to peak exercise at 7 minutes, where the heart rate was 135 or 82% of age predicted max, he accelerated to 135 at the end of the exercise test, and so we stopped the exercise. And so I was concerned that he was going into some kind of VT here. I'm really not sure whether he's paced or this is a ventricular tachycardia here, a slowish one. I'm not sure. I can't really tell from the surface ECG, and I really wouldn't like to make a guess at that. When we rested him, recovery at 10 minutes, he was back almost exactly to what we had pre-exercise, and he was clearly being paced again in recovery. So just to show you how I can use a fit test to work with these sort of clients who are quite sick, long history of coronary artery disease and then heart failure, and also being paced. And you can work with these clients very successfully. So thank you for listening to the video. And as always, you can contact me at info@myfittest.com.au, and have a great day and look after yourselves. Bye for now.